Welcome to the Lymphoma Research Foundation's Update on Peripheral T-Cell Lymphoma webinar. I'm Crystal, and I'll be the moderator for today's call. During today's call, you will hear from an expert speaker, and you'll have an opportunity to ask questions. If you have questions during today's presentation, you can ask them at any time in the Q&A box on the webinar. If you are listening by phone, you'll be able to ask your questions during our Q&A session. As a reminder, this webinar is being recorded. At the end of the program, a link will appear on your screen. Please follow this link to complete an evaluation of this program and gain certification of attendance. If you are listening by phone, this link will be sent to your email at the end of the webinar. And now I'm pleased to introduce Jessie Brown. Jessie Brown is the Associate Director of Patient Education at the Lymphoma Research Foundation. Welcome, Jessie.
Thank you. And thank you to each of you for taking the time today to join us on today's Peripheral T-Cell Lymphoma webinar. We'd like to thank our sponsor of this webinar, Seattle Genetics. We have callers from 41 states across the U.S., as well as patients and caregivers from 10 countries around the world. Access to expert disease information is so important, and we are thrilled to be able to bring you this educational program. We have a wonderful program planned for you today, and I'm honored to introduce you to Dr. Neha Medishaw. Dr. Medishaw is an assistant professor of medicine at Washington University School of Medicine in St. Louis. Dr. Medishaw's research has been focused on prospective and retrospective studies to better understand the biology of and to improve therapy for patients with peripheral and cutaneous T-cell lymphomas. She also was a member of LRF's Lymphoma Clinical Research Mentoring Program, where her project sought to develop a method for identifying residual disease in PTCL. Dr. Medishaw, I will now turn the talk over to you.
Thank you so much for giving me the opportunity to speak today. I'm going to start by covering a little bit of the basics because we're talking about some relatively uncommon lymphomas, and I know some of you may be caregivers or may not have had the opportunity to learn about peripheral T-cell lymphomas from in the clinic itself, and then I'll go further into what we're working on in peripheral T-cell lymphomas. So what we hope you'll learn today is an overview of peripheral T-cell lymphomas, some of the treatment options in the upfront or frontline setting we call, or second-line therapy, so people who didn't respond initially to their first line of therapy. What are some new and emerging treatment approaches in peripheral T-cell lymphoma? Some mention of promising clinical trials that are currently ongoing, and then we'll leave plenty of time for questions and answers because I think that's the part that all of you are probably looking forward to the most. So to start off, lymphomas come from lymph cells. So lymphomas are cancers of lymph cells, and your body has many types of cells, including cells in the blood system. These are red blood cells that carry oxygen, platelets that help with blood clotting, and white blood cells that are involved in infection. And lymphocytes are one portion of those white blood cells involved in coordinating the immune system's response. Everybody has lymphocytes, and those lymphocytes are often organized in lymph nodes throughout the body, and you have over 600 lymph nodes in the body. And these track along where your blood vessels are, as seen by the green dots in this diagram over here. The spleen, for example, is another lymphoid organ or full of lymph cells. So essentially, lymphomas are cancers of the lymphatic system, which is a component of the immune system, and therefore they are a form of blood cancer. When these lymph cells learn to grow on their own without response to an infection or inflammation or trauma, their normal jobs, then they can become a lymphoma. And most lymphomas present in lymph nodes, but you can have lymphomas in any part of the body, as these cells are known to circulate throughout the body. So many types of lymphomas can exist in the gastrointestinal tract or the bone marrow, or even in the brain and the central nervous system. And just to remember, if you're freaking out about having enlarged lymph nodes, not all enlarged lymph nodes are related to cancer. Only 1% of patients who present to a primary care doctor's office with an enlarged lymph node really have a form of cancer, let alone lymphoma. So this diagram is about B-cell lymphomas, but I think it articulates an important concept, and that we think that lymphomas arise from a halt in the normal maturation process of lymph cells. So lymph cells are supposed to grow up in the bone marrow as a stem cell. That's all the way on the left of the diagram. And then as they grow a little bit older in the bone marrow, they acquire different proteins on their surface and will lose certain other proteins on their surface. And then as they grow a little bit older, they leave the bone marrow and then acquire different proteins on their surface and then take away other proteins. That normal maturation process helps us understand which lymph cell a lymphoma is derived from. So if you take the very baby cells, the ones in the bone marrow, maybe you can call them even the infant cells, when they stop to grow up at that point, they can become leukemias. If you have cells that are slightly more mature but not very mature, you can think about them as like toddler cells, and they stop maturing at that point, we consider those aggressive lymphomas. Lymphomas derived from those cells. If they're like teenager cells in the midst of differentiating a little bit further into more adult cells, those could be like mantle cell lymphoma, which comes from the mantle zone. And then there are more mature lymphomas that come from more mature lymph cells, and those are characterized as indolent or slow-growing lymphomas, and the classic example of that is follicular lymphoma. The T-cell maturation process is a little bit more complicated to draw out, and so this is a very overly simplified diagram that comes from our medicine textbooks, where you can see that the infant cells are all living in the thymus, and then post-thymic, or cells that have learned some antigen, have had some antigen exposure after that, can develop into more mature T cells. And that's where you get the peripheral and cutaneous T-cell lymphomas. And of these, there are lots of different types. So there's about, if you look at now talking again about all non-Hodgkin's lymphomas, there's about 15,000 cases of lymphoma per year. The incidence in the United States is rising. It makes up about 4% of all cancers. And if you look at about 10% of these lymphomas are Hodgkin's disease, and all the rest of them are non-Hodgkin's lymphoma. And there are about 90 different types of non-Hodgkin's lymphoma. And the goals and the methods of treatment differ based on what type of lymphoma you have. So now to focus just on T-cell lymphomas. So T-cell lymphomas are a form of non-Hodgkin's lymphomas. All of the non-Hodgkin's lymphomas, we say about 80% of them come from B as in boy cells, and 10% come from T cells. These are roughly divided in half into cutaneous and peripheral T-cell lymphomas. So cutaneous T-cell lymphomas are lymphomas that are predominantly on the skin, sometimes the blood and the lymph nodes, but usually present in the skin and usually are limited to the skin. And the peripheral T-cell lymphomas are those that we call systemic T-cell lymphomas. And the majority of this talk is going to focus on peripheral T-cell lymphomas, but I'm happy to talk about cutaneous T-cell lymphomas in the Q&A session. So peripheral T-cell lymphomas are a rare subset of non-Hodgkin's lymphomas. They make up about 7% of non-Hodgkin's lymphomas. And that 7% of non-Hodgkin's lymphomas actually represents 19 different types of cancers altogether. And each of those has a different clinical presentation and a different way they look under the microscope. The average person who has these diseases is in their mid-60s. And the treatment previously had been derived from what we knew of B-cell lymphomas, which were much more common. And only now are we starting to understand how different subtypes of T-cell lymphoma could be treated differently and trying to apply that to our patients. The most common forms of peripheral T-cell lymphoma are peripheral T-cell lymphoma not otherwise specified, which is abbreviated PTCL-NOS. The next most common subtype is called angioimmunoblastic T-cell lymphoma, or AITL. The next most common is anaplastic large cell lymphoma, abbreviated ALCL. And that gets divided into those that express the protein ALK and which ones don't express the protein ALK. And I bring up these abbreviations because you might see them later on in the talk. And as I mentioned earlier, we're learning that different histologies actually have different biology, and that hopefully is going to lead to improvements in our ability to treat different patients based on the biology of their cancer rather than lumping all these cancers together. So how do we get to the right diagnosis? And unfortunately for patients with peripheral T-cell lymphoma, this is a formidable challenge. The diagnosis of lymphoma often occurs through some sort of biopsy. That could be a needle biopsy, as a radiologist might do a biopsy using a needle and an ultrasound or a needle and a CAT scan, or a surgical biopsy, meaning removal of a lymph node or some piece of tissue. And then what they do is they look at the histology. So they look at how those cells relate on a slide next to each other. How many of the cells look abnormal or angry? How many of them, what kind of formation do they have relative to each other, and where do they occur with respect to the rest of the lymph node? Then they do something called staining or immunohistochemistry. That's to look at which proteins are on the surface of the cells. Then we also do something called flow cytometry. We sometimes call those markers, and that's to look at which proteins are co-expressed on the cell. So do the cells express a protein called CD3 and a protein called CD30 on the cell? And that test can be done by immunohistochemistry, but is even more precise with flow cytometry. And then we do molecular testing, or which often in T-cell lymphomas relates to T-cell gene rearrangements. So each T-cell is supposed to have a unique barcode with a T-cell receptor, and each group of T-cells has a different T-cell receptor barcode, just like barcodes at the grocery store. And you can see if the cells are predominantly express the same barcode or different barcodes. So are you buying only, if you're only looking at Cheerios, are the Cheerios all honey nut Cheerios, or are there multigrain Cheerios, or can you not figure out if the Cheerios even relate to each other? And that's kind of what the T-cell gene rearrangements help us understand. Then the hard part is often that the diagnosis of T-cell lymphomas can be challenging. These are rare diseases. Community hematopathologists or pathologists who are used to looking at blood cancers may not see that many of these. The diagnosis itself can be challenging to make, even in expert eyes. And there have been studies that have been done to show that if you take a pathology specimen between a community pathologist and an academic medical center, there can be a shift in the diagnosis in up to a fourth of cases. That's not sometimes moving it in or out of the category of peripheral T-cell lymphoma, but might change the subtype classification of T-cell lymphoma. So I'd like to emphasize that expert pathology review is really important in this disease. So how do we know where the lymphoma is? We do this by staging. So that's by doing scans or pictures. This could be a PET scan or a scan where you get a radioactive sugar to highlight areas of concern for lymphoma, or CAT scans. And then we often do bone marrow biopsies in this disease, as we think that the PET scans or CAT scans often underrepresent disease in the bone marrow. We stage patients with peripheral T-cell lymphomas very similarly to how we would stage patients with other forms of lymphoma, and this is using the Ann Arbor staging system, where we look at how many areas of lymph nodes are involved and whether they're involved on the same or opposite sides of the diaphragm. Cutaneous T-cell lymphomas and a rare disease called breast implant-associated anaplastic large cell lymphoma has a different staging system. There are multiple treatment options, and this is just to give you some idea. We're going to go through some of this more, where patients can get chemotherapy. There's sometimes a role for radiation therapy. There's sometimes a role for antibody-based therapy. We'll talk a bit about the role of immunotherapy or medicines to boost the immune system to fight the cancer. Antibodies tagged to chemotherapy to help deliver chemotherapy, and then targeted therapies, as well as stem cell transplants. There are two types of stem cell transplants I'd like to just explain. There's autologous or from your own cell transplants. These are basically giving high-dose chemotherapy and then giving your own stem cells back to you to help repopulate the bone marrow. So the principle is that you're giving high enough dose chemotherapy that the bone marrow will be very weak as a result of that chemotherapy, and so you give your own stem cells back to the body so that the normal blood system repopulates, and that's usually happens within a couple of weeks of the infusion. So the main component of that therapy is the chemotherapy. Allogeneic transplants or donor stem cell transplants are replacing your immune system with someone else's in hopes that the new immune system fights the cancer. So totally different mechanism and different risks. So this is essentially my paradigm for treating peripheral T-cell lymphomas, and I'm just going to quickly go through some of this. So in patients who have untreated peripheral T-cell lymphoma, I use 4 cycles of CHOP-based chemotherapy, so chemotherapy that involves some of those medicines. And after 4 cycles, I get a scan. And then if the scan looks good, I give 2 more cycles of therapy. And then if the scan continues to look good at that point, I consider a stem cell transplant from your own cells. And the reason we do this is because we think that about 1 in 5 people may benefit from a transplant, meaning they may have a longer duration of remission or a higher rate of cure with the transplant than without the transplant. So if you're in good health, we consider a transplant. This remains an area of controversy in the world of peripheral T-cell lymphoma, and there are some studies to support this paradigm of treatment, and other studies that seem to suggest that it may not be as important to get a stem cell transplant. And so I would talk to your individual physicians about the role of transplant in your specific disease, as I think there's a lot of room for personalized discussion regarding care. In terms of curative treatment options, I mentioned our backbone is CHOP, which is 4 different medicines, 3 chemomedicines called cyclophosphamide, doxorubicin, vincristine, and then prednisone, which is a steroid medicine. You can consider adding etoposide, which is another chemotherapy medicine, to CHOP, and this we sometimes abbreviate as CHOEP. And then there's the role of brentuximab, which we'll talk about with components of CHOP, cyclophosphamide, doxorubicin, and prednisone. And this is now the standard of care for anaplastic large cell lymphoma, and we'll discuss briefly why. So brentuximab vedotin is an antibody tagged to chemotherapy. So it's a little antibody against a protein called CD30, which carries with it a chemotherapy molecule. And then by delivering drugs this way, the brentuximab antibody will deliver chemotherapy to the areas of known lymphoma, and ideally with less side effects, and that's what we've seen. So when there was a large international study that was presented about a year ago at our annual meeting, which was where patients were randomized to either getting CHOP chemotherapy or brentuximab with the CHP regimen. And the patients didn't know what they got. The physicians didn't know what they got. This was called a double-blind, double-dummy international randomized study, phase 3 study. And what they did was they took patients who had CD30 expressing peripheral T-cell lymphomas, meaning more than 10% of the cancer cells looked like they had CD30 expression, and saw whether adding brentuximab to your initial therapy improves outcomes. And they found that the progression-free survival, or the time to progression, was twice as long for people who got the brentuximab-based chemotherapy. And in fact, they saw that patients may live longer if they get the brentuximab-based therapy. The majority of the patients on this study had anaplastic large cell lymphoma, which always expresses CD30. And so we think this is the group that most benefits from this approach, but discussion of whether this therapy would be appropriate for you is important to have with your individual physician. So there are lots of efforts to improve on CHOP-based chemotherapy. There's a study of brentuximab vedotin with CHOEP, so the CHOP with the etoposide-based therapy. And that's being done at a number of major cancer centers, including City of Hope, MD Anderson, Ohio State, the British Columbia Cancer Agency, and Hackensack Medical Center in New Jersey. And then we are participating at WashU in a study of CHOP plus 5-azacitidine, which we'll talk about a little bit later. That's a medicine that helps modulate which genes are expressed by the cancer. That's being done at Cornell by Gia Ruwan, Memorial Sloan Kettering, us at WashU and Moffitt. And there's an international European study where people were randomized to romidepsin, also another drug that modifies which genes are expressed by the cancer cells, in combination with CHOP versus CHOP. And we hope that that result may be available for next year. So what happens if my cancer comes back after CHOP-based chemotherapy? We call that relapsed or refractory peripheral T-cell lymphomas. We think that allogeneic or donor stem cell transplant can be curative. This was based on a series of over 350 patients who were treated with an allotransplant with peripheral T-cell lymphoma, and the cure rate is up to 50% of patients at 3 years. The prognosis for people who cannot get an allogeneic transplant is relatively poor, and most patients die of their disease in many months from that time point. So my strategy for these patients who have their lymphoma come back is to consider first, are they eligible for an allogeneic transplant? If they are, then I consider treatment that might have a high rate of response, even if it has slightly higher toxicity, because the goal is to just get them to the transplant as soon as possible. And so while I am looking at donors and communicating with the transplant doctors, we are giving sometimes combination chemotherapy or study therapy. And for patients who are not eligible for an allogeneic transplant, the goal is to keep them in remission for as long as possible while maintaining their quality of life. And so this could be single agent drug therapies, sometimes combination chemotherapies, and also therapies and clinical trials. So there are 4 FDA-approved medications for patients who have had their lymphoma come back, and these include romidepsin and belinostat, which are drugs to help modulate gene expression in the cancer cells. There's a antifolate chemotherapy medicine called pralatrexate, and then there's brentuximab, as I mentioned earlier, which tends to be better for anaplastic large cell lymphoma. But the duration of risk, as you can see, the overall response rate leaves something to be desired. About 1 in 4 or 1 in 3 patients will respond to any one of these therapies, with the exception of brentuximab. And the duration of response is also limited. So even if people achieve a response, they may not last for as long as we would want. There are many promising therapies. I'm going to briefly talk about some of these. They include romidepsin-based combination therapies, inhibiting something called the JAK-SYK pathway, inhibiting a pathway called PI3 kinase, and then checkpoint inhibitors or immunotherapy. So there have been a number of studies of romidepsin-based combinations. I've been involved in leading a couple of these, of romidepsin with lenalidomide or romidepsin-lenalidomide with carfilzomib. Lenalidomide is an immunomodulatory oral drug used in multiple myeloma and many forms of indolent lymphoma. There is a study of romidepsin plus 5-azacitidine, that's the hypomethylating agent, that can change the way genes are expressed in the cancer cells as well. And there's also a publication combining 2 of the FDA-approved form treatments for peripheral T-cell lymphoma, romidepsin and pralatrexate. And overall, we see that these are relatively small studies, and they show that patients with T-cell lymphoma can have response rates above 50% when using these drugs in combination as opposed to using them on their own. And there's a thought that angioimmunoblastic T-cell lymphoma may be more sensitive to romidepsin-based combinations, and that's an area of active investigation currently. But keep in mind that these are all relatively small studies of up to 20 or 30 patients, sometimes only 10 or 15 patients, and so big conclusions are hard to make from these small experiences. Then there's inhibitors of the JAK pathway. So JAK and SYK are important proteins in cell signaling and telling the cell when to replicate and when to upregulate genes. And so there's a drug called certolatinib, which inhibits JAK and SYK, which was recently also presented at our annual meeting, which showed an overall response rate of 35%. But in patients with angioimmunoblastic T-cell lymphoma, the response rate was up to 50%. And so this initial study, which was just exploring the use in T-cell lymphoma and other lymphomas, has led to a large international phase 2 study that should be opening soon at many centers around the country. Additionally, Alison Moskowitz, who's at Memorial Sloan Kettering, did a smaller study of a drug called ruxolitinib, which also inhibits a JAK protein, and showed that the response rate to ruxolitinib was 23%. But if you were able to identify mutations or activation of the JAK pathway on the biopsy, then the response rate could be higher, up to 40 or so %. that tells me that there's things about the biology of these diseases that can be looked into further to help in the future figure out a way to better personalize therapy for our patients. So duvelisib is a PI3 kinase inhibitor. So PI3 kinase is an important pathway in the T-cell receptor signaling process. And in a very early study of duvelisib, which was being explored in all sorts of blood cancers, everyone was surprised that the 16 patients with peripheral T-cell lymphoma and the 19 patients with cutaneous T-cell lymphoma had a good response. And in fact, up to 50% of patients were responding. And so this led us to then study this further. And so we started this study while I was at Sloan Kettering, and then carried it forward to Stanford, Dana-Farber, and WashU with the support of the Leukemia Lymphoma Society to look at duvelisib in combination with other therapies such as romidepsin or bortezomib. And we found again that the response rate in this also relatively small study was about 60% of patients responded to duvelisib-based therapy. And in fact, about a third of patients had a complete response, and that was often early in their treatment. So we again were quite intrigued by this, as was the company that makes duvelisib, which led to this study, which is called PRIMO, which is a study of single-agent duvelisib that is currently open and accruing, and we're past the optimization dose phase, and so the study is currently looking to in the dose expansion phase where everybody gets duvelisib, and there's no placebo, and we're hoping that this may lead to further justification to register this drug as an option for our patients. Tenalisib, similarly, is another PI3 kinase inhibitor that is currently under study. There was a study that was presented a couple of years ago at our annual meeting that showed that tenalisib can also have a response rate above 47% or so. And this is now being studied as a single agent and in combination with romidepsin in a study that's also open throughout the country at a number of sites. I think this pathway is clearly of importance in peripheral T-cell lymphomas, and we're looking forward to figuring out which patients best benefit from this. So ALK is a protein that's expressed in certain subtypes of anaplastic large cell lymphoma. It's also a protein that's expressed in certain types of lung cancer, and in lung cancer they developed a drug called crizotinib to study ALK to study ALK-positive lung cancers. So people said, well, why don't we study this in peripheral T-cell lymphomas that express ALK? And a study from the Children's Oncology Group in anaplastic large cell lymphoma that expressed the protein ALK showed that the response rate was up to 92% of patients. And so this drug is available and is what we call NCCN compendium listed for patients who have ALK expressing anaplastic large cell lymphomas. So briefly about immunotherapy or medicines to boost the immune system to treat the cancer. The normal immune system has a number of brakes and accelerators to modulate the immune system, and checkpoint inhibitors, which you may have heard of, take the brakes off the immune system and allows the cancer to be uncloaked or undisguised from the immune system. And then your normal immune system hopefully will find the cancer cells and kill them off. The T cells are an important part of that process, so there's always been a concern that in T-cell lymphomas, by giving these medicines, could you help treat the cancer or could you hurt the cancer? Meaning, may you be able to leave the T-cell lymphoma unregulated as well? So in some types of peripheral T-cell lymphoma, it's been found to be extremely effective. These include NK T-cell lymphomas or cutaneous T-cell lymphomas. There's been a higher rate of clinical benefit from these families of drugs, but in other forms of peripheral T-cell lymphoma, it's been reported that this could be associated with worsening the pace of disease, and so I would encourage you to talk to your doctors about the role of this and whether it would make sense for your cancer. So my paradigm has been that it's really important to enroll to studies. Not only are novel therapies very promising, but the goal is that they may have less toxicity and they may be more effective than some of the standard therapies that we have available. And so it's very important to consider clinical trials in the world of peripheral T-cell lymphomas. So briefly, just until recently, and I think we have been searching essentially in the dark, but we lately have been shedding light onto these rare diseases and how they work to better understand how to treat them. There was a large study done by Javid Iqbal, who's at University of Nebraska, where he looked at the gene expression profiling in multiple forms in 372 patients with peripheral T-cell lymphoma to look at which genes were actually upregulated in the cancer cells. And he was able to find that sometimes looking at that profile, you would be able to better understand which category of peripheral T-cell lymphoma the disease fell into. And so this is currently being explored. We're also looking at minimal residual disease in peripheral T-cell lymphoma. This is a project that's being sponsored by the LRF as well as the T-cell Leukemia Lymphoma Foundation to look at blood markers of peripheral T-cell lymphoma and to determine hopefully determines who's benefiting the most from combination chemotherapy and who could benefit from an auto transplant. And so this study is being done at WashU, Memorial Sloan Kettering, and Dana-Farber. And there are lots of efforts to better articulate the biology of peripheral T-cell lymphomas. We're in collaboration with the National Cancer Institute to sequence 500 cases of peripheral T-cell lymphoma internationally and to also look at gene expression profiling. The International T-cell lymphoma registry includes both clinical data and a biobank that includes looking at cell-free DNA to better understand can you find the cancer in the blood at a minute level. Carefully designed clinical trials with biopsies that are being done while patients are receiving study therapy have led to major advances in the thought process and understanding which patients respond and which patients don't respond to therapy so that we can better develop trials and to give better patient care for patients in the future. Some of this has been done by developing what we call patient-derived xenografts. So this is from Dave Weinstock and being pursued by Dave Weinstock and Giorgio Ingarami, where they're developing mice that mimic the pattern of lymphoma by injecting a patient's lymphoma tumor into a mouse and then recapitulating what the biology of that disease is in the mouse, which allows us to understand how both these diseases develop and also test drugs in the mice before we would test them in humans. I can't emphasize enough that I'm really fortunate to be working in a community of people who are really passionate about what they do. The peripheral T-cell lymphoma community across the country and across the world is very much united to try to treat this disease and to make treatment better for patients. And so I get to work with all these passionate, intelligent people all over the world who are really set to accomplish this goal in tandem. So what can you do to advocate for yourself? I think being informed is really important. That could be by being informed through your physician. Take advantage of the resources through the Lymphoma Research Foundation, which has fantastic resources. I would encourage you to talk to others about your lymphoma. I think if you talk to people about it, then people are less scared to talk about it and ask questions of each other and ask questions of their clinicians. Some of my very best ideas come from the patient room where a patient asks a question and I say, actually I don't know why we do it that way and maybe we should think about doing it a different way. Consider clinical trials and support research and be active in your community and your support groups, and that means, at the local level, at the statewide level, at the national level, and be cognizant of the opinions of your elected officials on scientific and clinical research. With that, I thank you, and I really thank the LRF for giving me the opportunity to talk to you all and answer your questions. We're happy to help you. I'm over at WashU in St. Louis, and we're always happy to connect you with experts near you as well. And that's all I have.
Thank you so much, Dr. Medishaw. Before we open the program up to questions, I want to share information with you on the Lymphoma Research Foundation that may be helpful to you as you navigate peripheral T-cell lymphoma and long-term survivorship. The Lymphoma Research Foundation is the nation's largest nonprofit dedicated exclusively to lymphoma. Our mission is to eradicate this disease through investment in the most promising lymphoma research and to serve those impacted by lymphoma through quality education and support opportunities. As we continue to make progress in advancing peripheral T-cell lymphoma research, We also want to ensure that you have access to the latest information about your disease. The Foundation provides comprehensive disease and treatment-specific resources, programs, and services, all of which are offered free of charge and have been reviewed by lymphoma experts. Most relevant to today's call, LRF offers a variety of lymphoma-specific resources, many of which you can access at the bottom of your screen if you're utilizing the web link or via LRF's website at lymphoma.org if you are on the phone. The LRF helpline can answer your specific questions about peripheral T-cell lymphoma, as well as discuss relevant treatment options and clinical trials. We also offer the Lymphoma Support Network, which is a one-to-one peer support program for people with lymphoma and their caregivers. The Lymphoma Support Network connects patients and caregivers with volunteers who have similar experiences to help give others strength to meet the challenges they may have to face. We also offer a comprehensive Peripheral T-cell Learning Center on our website at lymphoma.org/PTCL, which aggregates all of the relevant information you may need to learn about this subtype of lymphoma and become an active participant in your treatment decision-making process. We offer a variety of publications that have been reviewed by peripheral T-cell lymphoma experts to ensure you have access to the latest information. We have a non-Hodgkin lymphoma guidebook and PTCL fact sheet, which can be found on our website or can be ordered for free through our helpline. Finally, our mobile app, Focus on Lymphoma, is an award-winning app that provides patients and caregivers access to comprehensive content, as well as unique tools to help manage your disease. The app is available for free download in the Apple App Store and in Google Play, and I would encourage you all to download the app today. And last, but certainly not least, for those of you who may be looking to give back and help continue to advance lymphoma research, I would encourage you to join Team LRF. We offer a variety of walks and rides for you to participate in, or you could turn your talents and passions into ways to raise funds for lymphoma research. Through Team LRF, you can meet others who have been impacted by this disease and join a community of individuals committed to impacting lives by finding cures for lymphoma. I really hope that you will take advantage of some of the great resources and services that the Lymphoma Research Foundation provides. If you have questions regarding what you learned today, or you need information about relevant treatment options and supportive care resources, you can reach out to the Lymphoma Research Foundation through our website at lymphoma.org or by calling our helpline at 1-800-500-9976. Thank you all again for your time today. We will now begin our Q&A portion of the program. Just as a reminder, please keep your questions as general as possible so that the entire audience can benefit from Dr. Medishaw's answers. And with that, I will turn the call over to our moderator.
Thank you. If you would like to ask a question, please press *1 on your touch-tone phone. We will take as many questions as possible, but if you have a question that does not get answered, you can always reach out to the Lymphoma Research Foundation's helpline at 800-500-9976. Our first question from the web, are there any immunotherapies being used to treat T-cell lymphoma?
Yes, I think that's an excellent question that I touched on briefly. So there are many forms of immunotherapy. The most common type talked about are those called checkpoint inhibitors, or medicines that help boost the immune system to kill the cancer and uncloak the disguise from the cancer cells to allow the immune system to recognize the cancer cell as being foreign. Those could include medicines like pembrolizumab or nivolumab. So in NK T-cell lymphomas, these have been found to be largely successful, where 60 to up sometimes even 80-90% of patients seem to respond to these therapies, which are being explored in clinical trials in the U.S. and internationally. Similarly, for cutaneous T-cell lymphomas, pembrolizumab was studied and showed that about 40% of patients responded, and of those who responded, they could have very long lengths of response to their therapy. In other forms of peripheral T-cell lymphoma, there was a recent report that came out of the Mayo Clinic that showed that giving these drugs could cause the cancer to grow faster. And similarly, at my own institution, Lee Ratner had published that in a rare type of peripheral T-cell lymphoma called acute T-cell leukemia lymphoma, or ATLL, which is associated with a specific virus called HTLV, that giving these medicines can cause the cancer to grow faster. So I think this is still being explored, and through a very cautious method, as we certainly want to make sure we don't hurt people with these drugs, but also want to figure out when we can use them to help patients. And I think mostly in the context of clinical trials.
Thank you very much. Our next question comes from the phone lines, and this is Andrew. Andrew, go ahead whenever you're ready.
Doctor, thank you very much for the very clear information. You talk about using allogenic transplant after a relapse or remission. We've heard a little bit about consolidating fairly soon after the rounds of CHOP before there's any recurrence of disease. What's your view on that?
Yeah, I think that's an excellent question. So this is an area of active exploration. There was a study that was done in Europe that showed that did an auto transplant or an allo transplant, and it didn't seem that doing the allo transplant helped. Like looking at a population-based test, at a population-based level seemed to help people, and the risks of an allotransplant are higher. So my personal bias is that there's a decent chance of being cured if you were responsive to chemotherapy with an auto transplant, and if that, which often has less toxicity, is sufficient to get you to cure, then to stick with that without going through the side effects of an allo transplant. But different people's diseases have different phenotypes and different persistence. So sometimes we consider an allo transplant after someone's first chemotherapy if it didn't work as well as we wanted it to. That's just my personal style to this, but again, everybody is looking at this slightly differently.
Thank you. Our next question comes from the web. Do you recommend taking biopsies from multiple sites or only from the largest lymph nodes?
That's also an excellent question. I often use the PET scans to help delineate where to do a biopsy. So some types of peripheral T-cell lymphoma tend to be more prominent than others on either a PET scan or a CAT scan. And so sometimes the PET scan will highlight areas of active lymphoma a little bit better. So that usually corresponds with the largest area, but sometimes not always. And additionally, biopsying a patient is a procedure that can have risk, and we strongly consider where that mass is or where the enlarged lymph node is when determining which process of biopsying to pursue, so we do the least harm to our patients while trying to get as much information as possible.
Thank you. Our next question comes from a caller on the line, and this is Beatrice. Beatrice, whenever you're ready.
Yes, this is Beatrice. I am diagnosed with lymphoma, peripheral T-cell lymphoma, and I received the CHOP. And then after a year after, when it relapses, they gave me I started receiving romidepsin. So the side effects right now, I'm about to finish the 4th cycle. I kind of very difficult to handle. So my question is, I'm trying to do the best to continue to complete at least the 6 cycles, what is suggestions from my doctor. What if I quit it before the 6th cycle?
Yeah, sorry, Beatrice, to hear that you're having a hard time with the treatment. I think it depends a bit on I think that's an individual decision to make with your doctor. That might depend on how well the medicine is working in you and trying to balance the side effects. Sometimes we're able to modulate the side effects by altering the dose or the schedule slightly to make it a little bit easier for patients if the treatment is working. If it's not working, then we consider changing the treatment also. And sometimes people feel, sick from either the treatment or from the lymphoma or both. So I would encourage you to have the discussion with your doctor. I think for patients who are on medicines like romidepsin or medicines that you might be on for a long time, talking about the quality of life on the treatment and how to improve quality of life on the treatment is incredibly important.
Thank you. Our next question comes from the web, and it reads, where can I look for clinical trials for PTCL?
That's a really good question. I think, so one great resource is to look on the LRF look and ask questions to the LRF. They often have information on which trials may be available in your area. I know when I'm looking for a patient who may be transitioning to a different area geographically, I look at clinicaltrials.gov or the website of some of the larger academic institutions in that area to see what are available. And your doctors can always reach out to some of us who are experts in the field who may know which trials might be more promising for a specific disease subtype. So oftentimes I get questions about that, and I'm able to refer people to doctors who are closer to them or trials that might be within reach that are open and enrolling close to them as well. But clinicaltrials.gov has a option of searching by disease type, and then you can look up all the trials actually nationally and internationally enrolling in a specific disease.
Thank you. Our next question comes from the phone lines, and this is Joseph. Joseph, go ahead whenever you're ready.
Doing.
Okay, Joseph,
can you hear me?
Have a question? Yes, we can.
Yes. So, excellent. So, I was advised that belinostat was within the same class as some of the other agents that you've named, but it's a little bit less toxic. Is there any reason within clinical trials that's not being combined with other agents, or is it actually being studied in combination as well?
That's an excellent question also, Joseph. So belinostat, you're right, is in the family of histone deacetylase inhibitors, and romidepsin and belinostat are drugs that are both working in the same class. So they change the way that genes are regulated by the cancer cells, we think, and that we think helps to fight the cancer. The schedule of belinostat is giving it 5 days in a row, whereas romidepsin is given weekly, and so that schedule has lent itself to combination trials for that reason. I don't think there's a reason why belinostat wouldn't be explored in other clinical trials. My talk was to give a summary of some of the studies that have been done recently that have been talked about nationally, but by no means was this meant to be comprehensive of every study in peripheral T-cell lymphoma that are ongoing. But yeah, belinostat and romidepsin are in similar classes, slightly different schedules and slightly different side effects, although pretty similar.
Thank you. Our next question comes from the web. Is adding brentuximab vedotin beneficial for a stage 4 ALK negative ALCL patient?
So if I understand the question correctly, it's that if you have ALK negative ALCL, would you consider brentuximab with your initial therapy for anaplastic large cell lymphoma? And I think the answer to that, after this recent Echelon 2 study that I discussed, which showed that showed progression-free and overall survival benefit to that combination, is yes, specifically with anaplastic large cell lymphoma. That was the question, correct? Or
yes.
Okay.
All right, so our next question comes from Joe, and Joe is on the line. Whenever you're ready, Joe.
Yes, hi. Just a quick question regarding CAR T trials. Are any of those showing promise for folks with PTCL?
Thanks for that great question. So yeah, so CAR T cells are genetically engineered T cells to help fight the cancer. These have been approved in a type of leukemia and in diffuse large B-cell lymphoma, and are rapidly under study in lots of different types of blood cancers as well as solid cancers. In T-cell lymphomas, as you can imagine, you'd have to engineer your T cells to fight the cancer, but not the CAR T cell or not the normal T cells, and that's been a challenge. There are currently studies being done at Baylor and University of North Carolina, Chapel Hill, to construct CAR T cells in peripheral T-cell lymphoma. There are similarly studies that are being done at the NCI and other centers across the country, and others that are soon to be opening as well. And so this is people are just starting to explore using CAR T cells in peripheral T-cell lymphomas, and there's very limited data to date as a result. Most of those studies are being done to see if, definitely to see if they work, but also to make sure that they don't cause another side effect to patients.
Thank you.
But there's
our next question. Oh, I'm sorry, go ahead.
No, I said, but there's a lot of hope for those strategies to work in peripheral T-cell lymphoma. It's just probably a little too early to say.
Okay, so our next question is from the phone lines, and this is Mark. Mark, do you have a question? Mark, perhaps you're on mute. On to our next question. Our next question comes from the web, and it reads, what is the latest research for hepatosplenic T-cell lymphoma?
That's a good question. So hepatosplenic T-cell lymphoma is a rarer subtype of peripheral T-cell lymphoma that tends to affect the liver, the spleen, the bone marrow, and sometimes for patients who have been on other immune suppressive medicines or immune altering medicines. There's some early responses in hepatosplenic T-cell lymphoma to some of the JAK-SIK inhibitors. These are all like 1 or 3 patient experiences, unfortunately, as these patients were not predominantly studied in these, they weren't the focus of this clinical trial, but some patients with those diseases did have good results. We, in that disease specifically, consider doing an allogeneic stem cell transplant early, as we've seen people survive this for many years with an allogeneic stem cell transplant, and the outcomes have been less good otherwise. People are trying to better understand the biology of that disease. Some of that is being done through big genomics projects internationally and nationally.
Thank you. Our next question comes from the web, and it reads, what role does Epstein-Barr virus have in PTCL?
That's also a very good and complicated question. So Epstein-Barr virus has been implicated in many types of lymphoma, including peripheral T-cell lymphomas, in NK T-cell lymphomas, which is one form of peripheral T-cell lymphoma. Epstein-Barr virus has a very high rate of being involved into the DNA and the RNA of those cancer cells, and you can actually follow the Epstein-Barr virus level to kind of track the lymphoma. In other forms of peripheral T-cell lymphoma, the role of Epstein-Barr in the development of the lymphoma is being explored and is a little bit controversial. It's most commonly associated with angioimmunoblastic T-cell lymphoma.
Great, thank you. And our next question on the web, and it reads, is there any benefit to adding etoposide to CHOP in frontline treatment?
Oh yeah, so that's a good question, one that we often talk about, amongst ourselves. So etoposide has been shown, I didn't show this data earlier, when you combine studies that use CHOP or CHOP with etoposide, the overall response rate is about the same, so the same number of people go into some sort of remission, but the number of people who go into a complete remission, meaning no evidence of lymphoma at their end of treatment scans, is higher with etoposide-based therapy, and that seems to benefit people under the age of 60 the most, and so we tend to consider etoposide for fit individuals. I personally don't use 60 as a line in the sand to determine who gets etoposide and who doesn't, but I strongly consider adding etoposide for patients who I think can tolerate it.
Thank you. And our next question comes from the web, and it reads, I'm on immunosuppressant drugs from an autoimmune disease. What should I stay aware of while I'm on treatment, as I've heard that autoimmune diseases and treatment can make me more susceptible to lymphoma?
So I think this is also a bit of a specific question. There's a number of immune suppressive agents that people may be on, and certain forms of lymphoma are associated with autoimmune diseases. So some of those immune suppressive medicines are medicines we commonly use to treat lymphoma, and other immune suppressive medicines can be medicines that can lead to progression of lymphoma. So I think having a careful discussion with your doctors about that is really important, because the clinical situation differs quite a bit. We sometimes see for patients who have autoimmune diseases that when we treat with combination chemotherapy, which we certainly wouldn't do all the time, but if in situations where that was warranted, that the autoimmune disease often does a little bit better temporarily with the immune suppression from the chemotherapy as well.
Thank you. And our last question comes from the web, and it reads, what is the role, if any, of brentuximab vedotin following successful treatment of CHOP in a 17-year-old patient?
Yeah, so I think that the question of when to use brentuximab in patients with relapsed disease or disease that comes back is based on whether the cancer cell expresses any CD30. I think our knowledge to date is that if you have even 1% of the cancer cells expressing the CD30 protein, which is the target of brentuximab, it's worth trying brentuximab, as those patients who have more than 1% expression can have a complete response to brentuximab. And so that's one of the medicines we certainly would go to as long as the lymphoma expressed some CD30.
Thank you very much. That's all the questions that we have today. Thank you again to each of you for joining us on today's call, and we hope you found the information both informative and also hopeful. Please remember, if you have any additional questions or would like to be connected with someone else who has been impacted by lymphoma, you can reach out to the LRF helpline at 1-800-500-9976. Also, at the conclusion of this program, you will receive an email prompting you to complete a program evaluation. I would ask that you please take a few moments to complete this brief evaluation, as they are really important for helping us to ensure we deliver the most useful and meaningful programming to you. With that, I would like to thank you all again for joining us, and have a wonderful day.